Yeah, and that's exactly.
Well, good morning, and
Say hello.
live on the webinar. My name's Tom Calma. I'm the chair patron of the Indigenous Health Network. It's a collaboration of 5 universities to look at Indigenous health. Greg and their philanthropy, $10 million to each of the universities to have a focus on Indigenous health. And this is one event that we're having today, which is part of a collaboration between the award-winning University of Sydney, I've seen University, territory of that operation, WA. So the three of us have in getting this event together. And I'll touch a little bit more on that in a moment. But can I also acknowledging on Aboriginal land and pay respects to and won't steal the thunder of our esteemed Ray Davison, who's going to give us the welcome to country, but I'd like to just acknowledge we are on Aboriginal land as we are across the Strait, and that it's important for us to recognise that, but also to not only recognise the elders, but recognise our youth, who are going to be our futures, custodians of our stories, our cultures, our history, languages, and that goes for all youth, irrespective of whether you're Aboriginal or Torres Strait Islander or not. Incumbent on all of us to grow our youth up. But can I invite now Ray Davison to, as a senior traditional owner for this area, custodian for this area, to give us a welcome to country. Right.
Thank you. Each time I have the opportunity to welcome the country or people to my clan land of the Eora Nation, I like to, especially for people that country or met me prior to those meetings, how much pleasure that it's time to be the person privileged enough to be allowed to give welcome to country. So to my traditional people, I say thank you. I'm here this morning. My name is Ray Davison. I'd like to good morning to our special guests over here. Good morning to all my Aboriginal and non-Aboriginal brothers today. I'm here this morning. Once again, my name is Ray Davison. I'm here this morning on behalf of the Metropolitan Local Aboriginal Lands Council. The Metropolitan Local Lands Council being the custodians to the clan groups of the Eora Nation, give me permission today and do welcome the country, even though it's my traditional land. So once again, it always gives me great pleasure. I like to do a little bit of a repeater when I because I like to. I know that, that there are people that I'm speaking to for the first time, so it's a first time experience. To know the land that we're on, the Eora Nation, and they're bordered by the 3 rivers of Sydney, and we the people of the Eora Nation regard those as sacred. And that's the Hawkesbury River to the north, the Nepean River to the west, and the Georges River to the south, and the ocean and waters beyond there. Within those boundaries are the 29 clans of the Eora people. My people, the Gadigal, I'm here representing today. I like the people as well. Like we all come from the same place, Mother Earth, and she individually and loves us all collectively. And I know that no matter what from or what nationality we are, we're all one. And especially I say those people, non-Aboriginal people that are born within my area, the Eora Nation. When I give welcome to country, I give welcome to country on your behalf as well as the Aboriginal people, because you're part of this country, same as the country's part of you. So once again, it's always a great pleasure to welcome to people to my land. And once again as well, not just from a traditional view, but from an Australian point of view, growing up, and I was only saying a moment ago to one of the young ladies there, no matter where I go in Sydney or what part of Sydney I go to give a welcome, I have a connection with that particular area or particular place. And this area here, naturally all over this alone, once again, growing up in Sydney, being born at La Perouse, and which I deem as the best place in Sydney and best place probably in Australia. Up, really diving for pennies as we did, and off the wharves, and people do actually go up there in that area, and again welcome people onto these, to my country is really exceptional. This building and all the buildings around, I was saying to the young lady, we're all part of the bond store. So once again, it's not just from a traditional point of view, it's from an urban point of view or an Australian urban point of view that growing up in this area, this actual building was part of the wool stores and the wool stores. And it's really, once again, like I said a moment ago, no matter where in Sydney I go, I've got that personal touch with it. So as a young man, I used to drive trucks and semi-trailers and delivering in and out the wharves and in and out these buildings here. And today, as a 64-year-old Australian to come back and be standing within a room like this and giving welcome to people, it's really, to me, it's been a journey. So a lot of people look around and see tar and cement, but also it's my traditional land. Every single day I'm on it, and when within my traditional land, I know that there's thousands and thousands of my ancestors around. Welcome to country, as you all know, may not know, as its origins on the east coast of Australia, and it's been around for many years. And we've always celebrated when we have big corroborees or by and it's doing it. It's no less. It carries the same importance, and in saying that as well, I give thanks to the state and federal government and private enterprise today for the importance that they give to welcome to country, because Aboriginal people have known that the importance of welcome to country, and we've had it for all those thousands of years, and we're part of it, and it's part of us. So to be able to share it today with non-Aboriginal people is a wonderful thing as well. So thank you all very much. I'm just going to read from this card here, Tom. 1 second. Because when you get old, you've got to do things slowly. It is now my pleasure, in accordance with our protocol, to take this next to the elders, both past and present, Eora people, and respect to colleagues and non-Aboriginal people here today, and welcome you to the land of the Eora Nation on behalf of the Gadigal clan. And as I say every time I'm finishing my welcome to country, and I say this in regards to what I just said a moment ago about thousands of my ancestors being around me all the time, because I know they are. May the spirits of my ancestors walk beside you and protect you while you're on Gadigal land, as I know they walk beside and protect me. So thank you all very much for your time and attention. I hope you have a wonderful day. Thank you.
Well, thank you, Ray, and I guess that really epitomises what we're on about today on health literacy, to not only just say welcome to country, but to give the explanation behind, the meaning behind why we have this messaging. And that's what I hope we'll get out of this forum. Can I also just recognise our panel members and who come from across Australia, and I'll introduce them separately. but to recognise their traditional owners and the other people who are watching this live broadcast from around the nation, and recognise their traditional owners also. We're now on our 6th Poche Key Thinkers Forum. We've held them in the last few years, and they've gone from anything from looking at cultural competency to alcohol and other drugs, the impacts, mental health. We've covered off on a range of issues on chronic disease and teeth and so forth. And I think it's an important one, this one, that we've got because of the topic. It's about bringing together a range of people to hear from a range of experts about a specific topic. And these topics aren't just dreamt up, they're what people within the industry or the sector have indicated to us that they see as a priority where they need some more. So we're hoping out of forums like this that we'll be able to impact policy and take it in a direction that is being taken. It's a session. It's a kind of a Q&A versus insight sort of presentation. We really and invite, and we might even just nominate you if you don't, to get involved. But today's health community gaps in Aboriginal health, and it's so which we'll hear just this on literacy, and literacy is an interesting. You might get a bit of debate about the use of jargon. If you look at the judicial system, where a lot of Aboriginal people have contact in, it's not understand the sense of being, being affected by. So this is what the issue is going. I hope you've all had a chance of the briefing paper. That we've got some here, and the pages in a website. Others will host it. Information on Facebook. Facebook.com/. And so if you, that's a paid ad, I must say, from Kylie. Paid ad, but she did get 700 plus followers of the Facebook, and you'll see on a wealth of information, but also documents in the Key Thinkers forums. So we have four groups of people today, and that's actually 5 speakers. The first is Nicola Dunbar, the Director of Strategy and Development of the Australian Commission on Quality in Healthcare. Then we have from the Peninjara Council in Nyunmiti Burton, and they're going to talk about the Urikula Inkaja project. Dawn Bessarab, the Director of Aboriginal Dental Health at the University of Western Australia, and our final speaker will be Associate Professor Kerry Taylor, the Director of the Poche Centre for Indigenous of Flinders University in the Northern Territory. So, as I mentioned, we're hoping for really frank, outcomes-focused discussions, and welcome you. Some phones. One will be from and Tam over the other side there. So put your hand up, or you'll be personally nominated if you don't, to ask a question. Encourage that. So just, and when you do ask a question, can you please yourself just the organisation you're from, We have a disparate group of people here across the nation. 6 groups of people live. Nation, I'm sure that others will be. And I'd like to acknowledge the live because they're the ones who have helped us take this live webinar that we're doing today. And people who are watching online will also have the opportunity to, and you'll see their questions. They won't be able to see what's up there. That won't be presented, but the questions will be out there. We'll also have some photographs, and if you don't want to be photographed, photographer know, or let us somebody who's wearing here, and they'll help. So at the end of the presentation, I'll be about 10 minutes. We'll be preparing the health literacy, and the important thing about that is just that whilst we frank and open, once the Poche opinion written, we won't be attributing any individuals. So generic type is going to be an important one, and as I said, it's we're looking
places, but also governments in terms of the policy framework around that, supporting better health literacy and supporting people to be better involved in their health. So there is absolutely a role for government there and for education and training organisations. That's just some of the roles. There's more on the document outside, but on the larger discussion that is on our website. I think that's a quick, I think very fast, but that's a quick Cook's tour of the work we've been doing at the Commission. Where we are now is really trying to, how do we embed this in our work? We've got some standards that the Commission developed and are now mandatory in countryside, and so we're looking at how we embed health literacy into there, looking at other ways in which we can actually support this and push it forward as a safety and quality issue. So I'll stop there, and if there are any questions, thank you.
Well, thank you, Nicola. That was precisely what we're after, a really quick overview of what's happening. And so there'll be an opportunity for questions, but I thought I'd kick off by just asking, each year the Prime Minister and the Leader of the Opposition at the federal level give a report back to Parliament about the Closing the Gap achievements. Is something similar being considered in relation to health literacy and what each of the states are doing? Or how do we know that, sign a document? Yeah. What are they doing about it?
It's a really good question, Tom. There isn't a similar thing. We have been working with the states and territories around the things that we're doing, but we haven't got that kind of national framework and reporting that there is for closing the gap. There has been some work that's happened in the Commonwealth over the last 12 months or so, and I haven't heard anything more about it for a while, so I don't know where it's at, where they were developing a whole of government framework around Aboriginal health, and we were contributing to that as part, our small bit of it. And we certainly raised health literacy as one of the things that we thought was important to include in that whole of government framework, and so there are some actions around health literacy in there. As I say, I'm not sure where that's at, and I don't know where it's going, and particularly in the change of focus and change of government, change of personnel down in Canberra. But I think we will continue to talk to our state and territory colleagues about this issue, and I think the inclusion of health literacy in a set of national mandatory safety and quality standards will help us to push this further as well, and really get a sense, hopefully start to get a sense. It's kind of going to be small baby steps, but hopefully that will help to push things along.
Yeah, because I think it's great that the Lyme network is actually involved in this, because that's where the other area needs to be focused on through the leaders in medical education to ensure that it starts to embed into curriculum and so forth.
Absolutely.
In relation to your question, the National Aboriginal and Torres Strait Health Plan, the implementation plan of that was launched by Minister Nash a couple of days ago.
Okay, good. I've missed it. I've been out of the loop on that.
And so that was a great example of collaboration between two governments, because it was an initiative of the previous government that was adopted by the current government, and through the whole process, Aboriginal and Torres Strait Islander people have led the whole movement, and we've been forefront in the presentation as well. Yeah. But it's something of a challenge, and that I'll make sure I keep a close eye to see that it is in fact taken seriously, because it's the implementation that really is important that we have to focus on.
Because I think, sorry, can I just, one thing I think we need to do is to translate this kind of concept, broad, somewhat amorphous concept about health literacy into action, and I think that helps. If we can get really discrete and concrete actions, it helps to put them like that.
A couple of questions down the front here. I'll get two down the front here. Microphone, to Vanessa or Tam, you got that one over there? Oh, you got mine. Sorry, I should take it. Oh, no. Sorry, I didn't realise that. I wasn't paid for this job now.
Hi Angela, my name's Vanessa.
I'm Nicola. Sorry.
Nicola, sorry.
That's all right.
Nicola, my name's Vanessa. My question is, have you been able to... myself. Sydney. Have you been able to measure how much health literacy is going on across all the different states and territories?
In terms of the amount of work that they're doing?
Yeah, and the different types of work that they're doing?
We did a stock take. One of the first things we did when we got into this space was to do a stock take around what was going on. And this was kind of 2011, 2012-ish. And we put a call out for kind of, tell us what you're doing about health literacy. Yeah. There's a report of that on our website. We didn't, it's not comprehensive at all. It's really not. We know there's a hell of a lot more going on out there. So we got 66 submissions covering about 200 different initiatives. And we looked at the kinds of work that people were doing, and they came from, states and territories, governments, universities, hospitals, local councils, insurance providers, all sorts of different people. And what we found was that about half of what people were doing was really focused on health information, providing health information that suited that was tailored to the audience. There was less focus about thinking about the environment and the way that the organisation worked, less focus around the policies and procedures. There was a reasonable number of things that were kind of about education and a reasonable number of... So that we've done. We haven't really done a kind of audit about what's going on around the country, but again, I think it's something that we could work with the states and territory colleagues about. Yeah.
Janine?
Yeah, thank you. Janine Mohammed from the Congress of Aboriginal Torres Strait Islander Nurses and Midwives. Nicola, as Tom said, health literacy is a whole of Australia issue, but the unique position that Aboriginal and Torres Strait Islander people are in, and also taking into the perspective of Aboriginal knowledges, ways of learning, what is the Commission thinking about doing in this space through an Aboriginal lens?
We haven't, in terms of health literacy, we haven't done anything in that space because we know that it's not our area of expertise, and that anything that we did, we would need to do with people. We couldn't just... we have started also someone who's sitting there is with my colleagues on our national standards how can to improve the health of Aboriginal. So that's kind of in that space. Like to do some work in that area, haven't done yet. If you want, I think the communities quite know where to start, and it's a complex field, so we don't want to jump in and expect to be successful. We need to work out what to focus on, because I think part of that is about, well, if we tried to fix everything, we would fail. So we would need to identify specific things to focus on and really, look for some specific opportunities.
Can I just say that part of inviting Nicola here today was acknowledging that there was a gap in policy, and that was, we hope that this will...
Yes.
Hi, Anna Whelan from Sydney Local Health District, Director of Health Promotion. I've only been there for about 8 months, and when I first started there was a group that was working on health literacy, but from that focus on health information and what do we provide to patients. We need to review thousands of documents. What we did was we came at it work, we and used it, circulated that to all the people on a working group. So we had people who come from the Health Equity Research Unit, from the mental health, lots of people who are passionate about let's get consumers, understanding what we're doing. Let's also get health professionals trying to communicate better. So we've got, the Education and Workforce Development Unit thinking about training. We were saying, let's make it mandatory, and they're saying, oh, we can't do mandatory training. Everyone says it should be mandatory. So lots of tensions and lots of good discussions, but it's really moving forward. So, we've had several draft, but the state that we're impressed with is Tasmania. They've done enormous work. So I think the work has been along that way. The dimension of health literacy, I think, is something we have to confront. Mental health consumers, it's one. many different types of consumers.
Yeah.
Thanks.
I mean, can I just comment on that quickly? I think the work, I'm on the steering committee around the Patient and Family Centred Care Initiative at Sydney LA, and I am just so impressed with what you, I think it's fantastic. Taking this concept, putting it into practice. So I think that, and I agree that has had a policy and literacy for and they led the way in terms of that. The work that they've done is good, and I would encourage those interested to have a look at their website. They've got some logos that they've made in the department, Department of Human Services and the hospitals in Tassie, kind of what it means and do something about it. I encourage you to have a look. They're really good. There is I think after Tasmania, the two states that are probably leading the way with health literacy are New South Wales and Victoria. So the Clinical Excellence Commission here in New South Wales are doing lots of good work around health literacy as part of their broader program about partnering with patients. And Victoria has always had a strong focus around consumer engagement and the whole doing it with us, not for us approach. And again, they've got a focus on health literacy built into that. So hopefully we'll be able to kind of, in terms of the agreement by health ministers around the national statement, and I think for us the national standards have been a huge driver about change in terms of safety and quality within health services. So we're really hoping that embedding these health literacy actions, specific actions in the standards and then the cross, will help to drive that.
Thank you, Nicola. Before we go to another question on the floor, we do have one, the Poche in Central Australia, Flinders Poche Australia, and their question is many different tribal groups in the region come into Alice Springs for surgery, but how do we make sure that the patients who are receiving or receive surgery are given adequate information to be able to make an informed decision? And whilst interpreters have been invited to or been offered to be able to work with so there hasn't been the take-up. That's the real. How do we get, be they surgeons or forth, to program?
An answer for that, because I think it's a really tricky question. I don't know what the solutions are. It's really, I know the complete providing, we've got so many different and trying to make that work. So I don't know the solution. What I can say is it's not just in Alice Springs. It's for every single person, who they are and where they're from. My colleagues read surgery, and she was a nurse and came out saying the consent process was complex. So I don't think that problem with consent is limited to Aboriginal people in Alice Springs. I actually think it's a problem across the board. It is something that we again around our how do you process, and that people have an understanding in their care and our partners in that decision making on consent, because it's difficult. There is legislation around consent in every state. What actually happens in practice is not necessarily reflected.
I think one thing that would be good too is to get an attitude shift around this issue of saving time.
Yeah.
People don't actually save time
No.
by going down the wrong path
Yeah.
or getting it wrong the first
Yeah.
time. So if people, if health practitioners start to think it isn't in saving time,
Yeah.
by to start,
Yeah.
and calling, there is, you know, some of the research I do reluctant to call on until we haven't got time. But to get it wrong.
Yeah.
So
And then have to fix it later.
Have to fix it later. So good.
Yeah.
And it's often any interpreter come and talk about complex issues like surgery or issues.
Yeah.
No, you don't.
You heard that one. Really good point that you raised about the consent, because first of all, it's a human right, free, prior and informed consent. I think part of the problem with that though is where it's centred around risk management, centred around the legal, and what you're talking about is really, and comment as well, I think you're looking at the environment as well.
Thanks. Thank you.
Sure, Suzanne Ingram, part of my Institute, currently doing my communication.
Good.
The doctor, please. Okay. We got one more down the back? Okay. Well, I think others there from what we'll, I think it's a great segue now that we're talking about the issues. Our next set of, thank you, Nicola, for your presentation, and we'll put the Nicola mentioned, where you can start to link from that to and others, I'm sure.
I can send those links through as well.
Okay, good. So can I now invite Nyunmiti, Burton and Angela Lynch to talk about the award-winning Utakula Chigara Jaku project. It's a project about the Nyunmiti program run by NPY Women's Council. And for those that aren't aware, the Nyunmiti's are actually traditional healers who receive special tools and training from their grandparents and other senior people within the communities, and they are still very active today. There's in fact a great book that was, I think, prepared by the Australian Indigenous Doctors Association about Nyunmiti. That's worth looking at. So, can I invite presentation? Who's first?
Thank you.
Hello.
It's turned on.
Yep.
My name is Nyunmiti. I would like to talk about women's cancer. There's a trial, and there are three languages, and we do lots of different. And there's 30 communities in that. We're coming together in the NPY Women's Council to talk about this. And I am a director for the NPY Women's Council and also an artist and a teacher and a leader.
I'm Angela Lynch. I work for NPY Women's Council on the Nyunmiti program. I'm just going to explain the Urikulinjaku, which is part of the Nyunmiti program. It's a group of about 20 Nyunmiti senior women, and they include people who are teaching various, and there's three men, two psychologists, and community nurse as well, this is the model that we use to what do you call it? Understanding and thinking clearly. we've been for about 2 years now, and we've done 11 workshop core program, and we've sort of up come to understand it after 2 years. So the main part of it is thinking
And so for me, it's such a valuable tool. And as you said about the different ways of using those things, like the fridge magnets, if people can't talk and you push a word across and they can, yes, that's how I feel. They're fabulous resources. They've been done in such a solid way that I really value them, really appreciate them. Thank you.
Thank you. Right.
Greg Ricard from the University of Tasmania, but I'm the director of the Roselle. Listening to the story being told by the front, what I was impressed about came as a privileged male, what processes do I go through when trying to understand other cultures and other communities, and what thinking work do I need to do, what supportive work do I need to do, what emotional do I need to do. It's the onus be on the dominant work with the other culture. It's comment rather.
Thank you. That's appreciated. And I think what we've heard is really reinforcing the sort of worldview of Indigenous peoples, and particularly in Australia, when we look at social emotional well-being, which is very much centred around culture, and what we've been trying to present to bureaucrats and politicians and others is that, when we look at any issue that affects Aboriginal and Torres Strait Islander people, we've got to look at it holistically and not just into certain issues, and we've got to look at both the social and cultural determinants, and what we've got here is that very presentation. If you want to address social and emotional well-being, look at the whole community view, and you can see aspects of it where people fit into it, and it does take time, and it's not easy to even affected through health and what it might take. Equally challenging for the health, but it is a challenge that we have to really address if we are going to have and see the outcome. We still have, a 10 to 12 disparity in life expectancy for Aboriginal and Torres Strait Islander people. We still have in every one of the indicators overrepresentation by Aboriginal and Torres Strait Islander people, all the health indicators, all the justice indicators, the education, we're underrepresented across it. So the whole issue, and this is why health literacy and literacy generally is so important, is if we want to be active players, if we want to be able to make really informed decisions, we need to be informed decisions. Comment.
I know from our evaluation, the mental health on the project say that learn something about them teaching Anangu something, it's that something themselves, and it makes their work more efficient, and that's their interest in coming, and they say they can start to see the world through the eyes of Anangu and start to see the way they think about things, and also learning the words is important too for starting conversations. Even if you can't speak Pitjantjatjara or Ngunnawal, if you have some words, you can help start a conversation that's got a bit more depth.
Okay.
Hi, I'm Patrick Dooley from Family Planning New South Wales. I'm a health educator going around New South Wales delivering programs around reproductive and sexual workers and also and Aboriginal. I was wondering if you could talk a little bit about the development of your for kids about sex, and especially how that might relate to women's business.
we haven't actually made it yet. It's just an idea, but what it is, we had a workshop with some child and adolescent mental health workers from South Africa who work at communities. They have the problem of child sexual problem, sexualised behaviour, and they were concerned about problem because it's it's a problem and it's really difficult and as you all know, complicated. And so one of the problems that the workers identified was that some of getting cases to go to court, like reporting it to the police and stuff, is really difficult, and often kids and family members just can't speak about it and can't give evidence, and the whole story falls apart, and it's very frustrating to them. So the women decided that they would help that process by creating a guide to how do you engage with kids, how do you talk about these really difficult things, what are the words used that sensitively. So we've been in small groups working on these kind of words, but what we've found is a lot of women say it's actually a lot of sign language. So yeah, it's a difficult, it is a really difficult thing to put in a written form. So we're just thinking about whether you can make a talking book or a video, or whether but we're still thinking about the process of it. But there's lots of that the women getting kids to draw instead of speaking, having different families, all that sort of information.
Okay, great. Thank you.
Thank you. My name is Dr. Smith. About to set up a orthodontic clinic in an urban situation at Mount Druitt at an AMS. And on this issue, I found perhaps one of the most important things is a sense of community in that AMS or any medical or dental clinic. And that was gained by having Aboriginal staff, dental nurses, for example, receptionists. And I remember from the early days I was rather frustrated, time used to a private practice. And someone said to me there are two levels of time, and I thought this was slightly insulting. There's Aboriginal time, there's European time, etc. But I got to understand that Aboriginal time is very significant in a clinical situation, because the staff, including myself, really engage with the people, and that does take time. They could be asking about Auntie so-and-so out at Narrabri or something else, but it gives a sense of community and confidence, and that was one of the most significant things I found in a clinic, that there should be Aboriginal staff who know the people, and they should have time to communicate in a clinical situation. That's my experience, and it's been very pleasurable gaining that information. Thank you.
Hi, my name's Jude Page from the Centre for Health Equity and Research. And also I'm holders of my story cards. I'm not sure if NYP, I know that you use the cards for a few years now. Opportunity, it's a based tool organisation, but it's a talk about some sensitive issues. I think might be some of your psychologists, youth team might use them. Yeah. That's I guess quite a developed with Aboriginal people to talk about some sensitive issues. So just another suggestion I might talk about later. And also, I'm sorry, just one other comment. I'm advertising, just received this morning, for people who might be interested in finding out how to work more culturally safely with Aboriginal people. The Adelaide POC Institute have just sent around a flyer, which I'll leave with Kylie.
Tom, we've got another question online.
Oh, really?
JR.
Well, I'll just read it out for those that can't see it down the back. And JR says that one way of approaching discussions with children about sensitive issues is to use a multi-literacy approach, including the use of visual literacies such as picture drawing, etc., to get kids to open up. This could also include music and dance and sign language, a total holistic, multilateral way of communicating. So that was in response to one of our questions. Thank you, JR. So do we have any last questions or comments here? And I should have mentioned before, and Kerry's already jumped in, but our panel members, you feel free to ask questions as well, if you like. Yeah, I know you are doing that. And I think the Aboriginal community controlled Aboriginal medical service is an important. That's one of the issues that often is argued by bureaucrats because consultations are taking too long, and it's one of the ongoing. Once you start targets and you're only supposed to spend X amount of time with them, and then when you come to an AMS, it's double that and triple that sometimes, and it doesn't take into consideration the whole communication profile that needs to take place. And I guess that's the issue that Nicola raised, and why I asked is that it's fine for health bureaucrats to sign up to something, but if they're not looking at it from a holistic picture, then it makes it very difficult. And I think one of the other big lessons for governments is to recognise that across the board through Aboriginal medical services, some have up to 50% of their patients are non-Indigenous people, and it's because the elderly, those who are not so health literate, will go to an Aboriginal medical service because they know that they will get the level of information that they need to be able to treat themselves and so forth. A question down the back. Great, thanks, Tam.
Hello, my name is Sydney Uni. A comment really about your last statement. In particular, the Aboriginal people that are not, Aboriginal and Torres Strait Islander people that are not accessing any services is my major concern around health literacy. There are key programs that are being funded to services other than AMSs and Aboriginal community controlled organisations. In particular, we've seen the move from Medicare locals into the primary health network. There is a program that was not tendered for, which was Closing the Gap program, about accessing for Aboriginal people that are not accessing any services. That program was just latched on to the primary health network system, and as a result, a number of those programs are not staffed by Aboriginal people, and so health is a major concern, and certainly the way the Aboriginal people, other dis-Aboriginal people, and those communities that don't have appropriate GP that they can approach. Concern is around, these programs not accessing point really.
Thank you, and I think the important that people, irrespective, have a choice as to what provider you want to use. I know that roughly just over 50% of the Aboriginal population use for Torres Strait Islander medical service. Other just under percent, the majority will use non-Indigenous health providers, including public hospitals and so forth. And there are a percentage that I guess is the only to get them engaged and because there's a lot falling. But as to whether they want an AMS or not, and that's the okay. So I've got a little cue card back there to say, please thank Nyunmiti and also Angela for their presentation. Another good thought-provoking to understanding what it's like in a location. People have multiple language challenges when it comes to England, have challenges of their own language. It's just English concepts, maybe. But look, what we're going to do now is just probably about 20 minutes. Some very light is outside, and so please feel free to enjoy. Come back in and be given the nod. Thank you again for. We'll see you back in.
Thank you. Mine started. I think there's something in the air. My eyes were watering, my nose was running, and I thought I was playing around it.
Yeah. Oh, it's a big city. Well.
the software is exactly to us as well. So she just suggested that I give you my card and just what context and stuff. Well, what you're doing is developing user resources. We're going to do very much of that. It's not doing again at that stage. So we've got it's a format. This actually comes under my communications company. And we wanted to do a very specific message to this. There is a perceived ownership from all of it. So, women's organisation runs it. It's actually completely that. So we're still doing which is it's been extraordinary. It's all good, and it's getting worse. It's getting worse. It's making meaning from again. Right. So what did you do? What did you do? Oh yeah, which and it wasn't an example, would you? Okay, because what you're talking about is oh, okay. What you're doing here is being in terms of culture, that's such an object. In terms of the definition, so everybody has to absolutely. Yeah. So, and you're essentially that's what I'm doing. That's like really and so would be the other right. Really
Basically asking a person in a wheelchair. Yeah, so one is these. It's a strategy.
That's fine.
Thank you.
Michelle says there's her mom. She's got families. And I've been pushing the focus sets that he listed instead of took it.
He's got the thing.
Oh, no, we could power up mine, so I can take it to him. Well, I'll send it to you as well.
Okay, good way.
You're up, Dawn. Sorry.
You better hurry up and gobble this down.
Yeah. They'll ask you a question right now. Have I got crust and everything?
Yes, they're very crusty, aren't they?
Yeah. Crumbs all over your always got stuff all over me.
Fortunately, it's from a distance, nobody will be able to tell.
Oh, that's good. Let's have a bit of salad.
Okay.
Question.
Who was that? Oh, John, not read them in.
Good, that's good there. That's good.
Okay, well, I think we're all ready. Everybody back online? Everybody but me. Well, thank you. Now move into the second half of our today, and you know, in the first half was great because we heard what's happening at the national level, and you know what the health ministers have signed up to. All of us now to help keeping them honest and doing, and I think a real challenge as Nicola had mentioned. Nicola hadn't mentioned it, but we all mentioned it. But the challenge for that look at plan, the bit that it's just done with on the health plan, having a very effective implementation, and that's the next step in that. We also heard about working in a language of Central Australia and what the NPY Women's Council and to be able to approach health not from a single dimension, but multi-dimensional, and to recognise you've got to look at social emotional well-being as well as physical health, as well as preventative if we're going to take early outcomes. The second presentation, presentations are going to take us a little bit and top off is in here, so I'll invite Professor Dawn Bessarab to contribute to the. Now, Dawn is a Winthrop Professor and Director of the Aboriginal Medical and Dental Health at the University of West Australia, and is a highly regarded Aboriginal researcher who advocates the importance of having an understanding of the cultural traditions of Aboriginal people. Her own research has enabled her to identify ways in which Aboriginal and non-Aboriginal service providers counterproductively of differing cultural. And today Dawn is going to be going to us the concept of language and accuracy and service in particular. So Dawn, can I hand over to you?
Okay, thanks for that, Tom. Yeah, just put the first slide up, please. I've just got definition of health literacy, and it's paragraph. Want to focus, and I guess it's Nicola to health literacy in kind of rested the receiver rather than the providers, and that focus is changing, and that's where I want to direct my conversation. So to shift the gaze away the Aboriginal clients of service to on what roles and responsibilities do we have in terms of organisations and providers of health services, how we engage with Aboriginal people and the types of things that we might need to consider when we talk about health literacy. So having said that, I think, you know, the conversation and promoting good health literacy now in developing not processes, good, efficient and capable workforce carry previously around the number of Aboriginal staff patients numbers at all. Health literacy, how we communicate, but it's around how do we employ and how do we represent people effectively within the health to work together with non-Aboriginal people on our own, but to provide a service to try and meet the needs of Aboriginal people from right across the different spectres and layers of the Australian community. The health literacy environment, which is more than just about communication but it's about processes, is crucial to improving good health population. And so the two most identified good health literacy that I was. Having said that, next slide please, Kylie. We know that colonisation and working in a centre for Aboriginal health where we provide health curriculum complaining about, constantly hearing about colonisation. Why can't Aboriginal? Great if we could do that. But one asking them if they don't understand. Now maybe that, but then it may point to where the person that's not speaking up could be a cultural thing. It's not about the individual. They may have heaps don't know how to ask, shame, or it's a power differential, or a whole range of things. So sometimes when you make that in a paper, you may need to unpack to show that it's a lot more complex and not so simple as simply saying that Aboriginal people don't ask questions, and if they did, it would help the health professional. Health professional's responsibility to also communicate that encourages an Aboriginal person. So health literacy is about how to continue in today's society and discontinue to repeat and regurgitate discourse that belongs, you know, that comes from about 100 or 200 or, you know, not 200, but that belongs to 50 years ago, 30 years ago. We need to use language and transform it, to change the thinking around Aboriginal people. Highly hidden messages, implicit messages. So we need to look at literature. Just because someone has written something in a particular way, particularly if we look at some of the literature written from the 1930s and the 1940s, and some things are seminal, people still repeat or still some of those people because of the work that they did. It is very highly laden. So just because someone has said something doesn't mean that we repeat it. We may need to actually reframe what they're saying. I guess in closing, how much time have I got? Yeah. Oh, sorry. So I guess my point is we've got Vince talked about thinking work. Alice Springs, the thinking. I think we have a lot of thinking work to do in relation to health literacy, how we are responsible for using language in a way that it becomes transformative, becomes non-deficit language, and actually starts to engage with Aboriginal people in a way that they can understand. We need to use different social ones that are now being created in Alice Springs, which start to show that there is a culture, there is a literate system in communities. We link into that to start to create worldviews that make sense to Aboriginal from the lived experience. And I think we need to also consider, one thing we haven't talked about here is a lot of Aboriginal people have difficulties because of otitis media in children. How many times I've heard people talking to someone and telling them, and the person is straining, don't understand, or they talk very fast and someone misses the words. So we need to think about how we pitch those messages to ensure that people can hear what we are saying, and particularly with our kids, because our kids have got high rates of otitis media. Translation. Another, how do we translate the Western story into an Aboriginal story that is understood by people and makes sense? And I think I take my hat off to your work, because I think that's where we need to go. Thank you.
Thank you, Dawn. I think, you know, implicit in what you were saying was really gets back down to that whole issue of cultural competence as well, and trying to put yourself in somebody else's shoes to understand their perspectives and their whole worldview reference. So, questions? One over there, and then Vanessa down the front here.
G'day Dawn, John Willis from St Vincent's Health. One of the things we know about the healthcare interaction, particularly in public hospitals around the country, is very fast-paced and very busy. One of the things, the question I had for you is that what seems to change health systems and health policy is evidence. And what would be lovely is to get some evidence talking about the clinicians being allowed more time up to deal with. And there's obviously lots of things space, but they're under the pump all the time, targets and all the rest of the things that go on in the health system. One of the questions is what research could we look at forth that evidence that would convince the policymakers that we need to change that pressure at the front, particularly in public acute healthcare?
Well, I think we've got enough evidence in the fact that we've got a whole program and it's called Closing the Gap, for starters, and there is already research out that shows that the fact that we're having a conversation around health literacy, it just depends on how the policymakers want to hear that message. And we know that when you've got people from other countries who come into the hospital system and English is not their first language, I don't think there's a second thought about whether they're interpreter or not. It kind of goes with, but there's always a second thought around whether, and I think that needs to change as well. So evidence out there, it's just a question of to different sorts of questions. Yeah.
There's a kind of evidence that communications are shorter with language people's English and other language. So we already know the consultation times. I don't know if it is. No, I think what I see is, you know, there's a lot of, again, and there's an anecdotal thing I would call qualitative. Doesn't get called qualitative.
I think also there's guidelines. I find it interesting in terms of around the surgery. Surely there are guidelines in place which would say you have to informed consent. It shouldn't even be a question. That if you know someone in surgery, you know, if you've got workers or Aboriginal liaisons in the hospital, it's how do you work with staff, have that conversation. I don't think it's, and see, this is where sometimes that starts coined within the phrase of the too hard basket. Aboriginal people are really hard problems, and when you start to go to that default space, a whole lot of other thinking and other things jump in. Yeah.
I think there's another point too that we forgot to mention before, is that Indigenous people can use English in a different way to like me, for example. So what we found was that sometimes people say, oh, you know, he's when they're being bullied or cheeky, and like that are sort of, and the English words that understate problems. So if you're talking, if an unknown person might go to someone in a clinic and talk about their problems in English, they might actually be trying to say something completely different to how they're being heard.
Yeah.
Tom, we've got a comment online.
Okay. Well, Vanessa, do you want to go first, and then we'll overread what the comment is.
Okay. My question is to Dawn. Hi, Dawn. Said that the literacy needs to, when you're getting older, take your glasses off to read, for Aboriginal people to know their culture, accountability of services, and the medics and the service delivery people, understanding and worldview. Like, measure that.
I don't know. Interesting question around measure it. I'm not sure about that, but I think it's around having conversations with people and talk to people about what is their worldview, meaning that your worldview is the same as, and as Angela, the way in which language, you know, we need that if using language that we both understand the same meaning.
I think that that's what I was saying. The accountability has to fall back onto service delivery as well, and not just changing that language so it's not just the fault of Aboriginal people, intelligent race of people.
Yeah.
So ability is, and how do we do that? Neutral ground.
Lots of assumptions around Aboriginal people. Within the justice about time, or even when you're talking about medication time, to work with worldviews. Not 7 o'clock, but maybe before breakfast.
Thank you. Now, the comment we've got from, again, folks in the Northern Territory, I believe that we could all strengthen communication, a holistic approach in engaging similarities, everyone see within themselves to be able to actively see others. And they're still typing, so it's almost 2 coming up. Okay, we got another question here. There and then over here, and all 3. Oh. Go. Yeah, you go.
Oh, hi, Dr. Poche. Following on from us to speak, there is, in terms, not just in terms of health literacy, talking about how do we organise on board the evidence, policy documents, and I think gap both in this and this area is in trying to ensure that as skilled can actually truly embed this within, because we've got systems, great thing. You know, I'm in care, and then we've got the AMIS services which are doing. But there are some services that are just not listening to the people, not listening, and the services. That's where we end. Some. So would you have strategies where we some to address this issue with is given that we do. I think that's pretty we're talking about.
Yeah, a much higher level.
I mean, that's a challenging question on how do you make services more accountable. I mean, one way is through their funding contracts. You know, like how, if they are breaking down, do they have a requirement to provide a service to Aboriginal people? And if they are breaking down, then why? I mean, often you will hear, I don't know about over this neck of the woods, but I know in Western Australia, you know, you'll often hear some organisations saying, well, we just can't get Aboriginal people to come to our service. And it's a fait accompli, rather than, it's the wrong question. Why? What is it that you may need to do or that you're not doing? And when you ask, do you have Aboriginal people on your board? No. Do you have Aboriginal workers? No. Or their Aboriginal workers leave. So I think it's around organisations being more honest, but this is where the bias, I think that gets in the way. Yeah. But the only way Aboriginal people and the concepts that we use, and that we don't continue to regurgitate some of the same old thinking that's been regurgitated for years. So that's how you change discourse. And I have seen that change happening, where I'm starting to see people, you know, the deficit view, where people are now starting to talk about strengths-based language, describing Aboriginal people in a strengths-based way, focusing on what is happening, what is the good things, rather than always what's going wrong. We know that, but it's around how we start to describe and represent. So I think we can do that.
Thanks. And don't forget, after this is all over, the formal presentations, when we have a cup of coffee outside, you can ask some of those questions and so forth. I leave you. Yeah, sorry. It's just that we're running a little over. No, very good session. But now we need to move on to one of our other keynotes, and that's from Associate Professor Kerry Taylor. And Kerry is the Director of the Poche Centre for Indigenous Health and Wellbeing in Alice Springs. She's previously worked in remote health, education and undergraduate nursing education. She has extensive experience working in Central Australian remote communities with a range of organisations, including Bachelor Institute of Indigenous Tertiary Education and the Northern Territory Department of Health. Kerry's PhD was a study of intercultural communications in healthcare and Indigenous language settings. Her main teaching and research interests include cultural safety, Indigenous health and health literacy. And that's why we've invited her along. Dr. Kerry Taylor.
Thanks. I'm going to take it from, we've had policy, we've had the big picture stuff, we've had some very practical examples and the worldview issues, which there was a method in the way we set it up today, and I hope that this afternoon, this last session is just for people who are relatively new to the issue of health literacy, who might like some just very practical tips. The comment that this requires a lot of effort and a lot of, you know, big picture thinking and system change, it absolutely does. But I also think that you can walk out of here today and implement some things that might be useful, and hopefully that gives people, you know, an opportunity to see that they as individuals can do something right now. I think we didn't start off, it's in the briefing paper, but 60% of all Australians have problems with health across the board, and so we add that level of complexity around differing worldviews and all of those things, and we know, you just will know that there will be a problem for people to communicate effectively. And some of the things that we can talk about are what the individual can do. So I've just put up here the issues, or the 4 areas that I think are worth having a discussion around. Written communications from health services are notoriously pitched at levels that are way too high for most people. And the average, anyone know what the reading age should be, what we should be pitching materials at? Is that, sorry? Well, yeah, year 8 ideally, and most stuff is pitched at year 10 and above. And so that leaves out a whole section of the community who just won't be able to access that information. And so just that as a start, there are things on your computer, on your Word programs, where you can go in and look at the readability of your paragraphs of text and try to bring it down to an appropriate reading age. I think what's happened is people have 3-4+ years of training in a particular discipline, and so the language becomes so second nature to us that it's very hard to then take it back to someone who doesn't have your whole picture. People are looking through a keyhole at the information that you're talking about, and it is great to see the health literacy changing the discourse to say it's actually the health practitioners who are required to change, not the people who are seeking your help. So written communications that are also written in passive language. The language of policy is often written in a passive sentences because it has to be broad, it has to be generalised. But that's not useful for someone who needs to take this medication away today and know how to work it. It's not, you should do this and you might do that, and if this happens. Those sort of sentences are really problematic for anyone who doesn't have English as their first language. The other things about written communication that, you know, often it's a practitioner who's essence of other content experts or target audience experts as well. So people can spend a lot of time making these beautiful resources and writing up brochures and producing these lovely works of art that someone takes away, and it's not appropriate for the target group that they're being delivered to. So just going through those sort of things, having a think about your reading age of your materials, who have you had in helping you and develop it. I really despair when I see how much time and effort people put in and they haven't tested the material. And the other thing is the verbal, as you said, and I do think it's very, very important to talk about Aboriginal English, because sometimes if someone is obviously speaking another language, wouldn't think twice about an interpreter or someone to come along. People are seemingly the same language. This is a key health literacy concept. Do you have a shared understanding? And one, just an example, at tea, you've had a day, I've only had one, and is this cup here, 150, 200 ml. And the picture, if we're out with the MPY, would be a cup like that big. So that's a very different quantity. Health literacy away. Do we have this in mind? And I think you get out into people's environments and ask them to show, you know, when you say you're having some, can you show me what you're, when you send someone home with this, they're really clear on what that means. The other thing here, the process that MPY used, a solid one, why it's taken to use those, because they're tested, they're workshopped, and then they're sometimes again important to have that test material and to have an evaluation as part of the process. Often that doesn't either. And the last one, and these are things doing, you know, just making it easy. There's up at the hospital at Alice Springs, for I've been there are yellow feet that lead the way to the pathology. So as some people say, where do you find pathology? I'll go out here, turn left, go there, do this, follow the yellow feet. You know, it's those sort of strategies which are well practiced, well founded and based on evidence about the design of the environment, about giving information in a way that's accessible. Places like and you know, playing to present material they can. The pocket cards are done by from the illustration, and we could take the health area, sure that they're understood symbols and things like that. Then they have to be taken particular suit that image. I think I just want examples, and I've chosen one very old example and one example. One on the there. That the intention was a positive one, but there are some unintended messages in that poster. I know we're not an interactive process at the moment, but does anyone want to suggest what unintended message that comes from the top one? If you can't see it, deaths in custody, homicide and violence, deaths from road accident. It's in prison, that is, yeah. Seriously, right. Or anyone, any other interpretations? It's not that big a problem? Yeah. Now I know that the people who made that poster would not think that, you know, obviously there's a great risk in road accidents, but it also, it minimises those other deaths. and I'm sure that's not the intention. It's also just a design issue there that you can see the first one is over as well. It's not even, so if you're trying to, it's not lined up. So I can go through and they ultimately get printed. And for me, I think, you know, steps before something actually, it should have to. Already? Really? It's good. I thought it was. And the other one is, it drives me crazy on the moment, liver campaign. And, you know, apparently livers climbing and skateboarding and all sorts of things. And I find this again challenging in an area where, you know, like to suggest that organs are out of their body doing things, you know. And again, you can understand that there was probably a good intention behind it. But if that is targeted at a particular group of people who would think that's because your organ could be off doing something independent of the body, you know, so these things are really important to think about. And I'm not putting these up to criticise the people who are involved in them. It should be a critiquing of what the work that we do at Poche Centre. We've tried to develop some resources. We've looked at them. We had a particular style to be, and then took them out and them a little bit, come back, and we keep changing. Unintended message. We were talking about some hygiene stuff. And of course, if graphics are then an unintended message that's relevant to you. I need to wash my hands. Aboriginal people do. I think the last thing I could just, you know, how health literacy varies the stuff that we're talking about is just giving a nation of why we ask people to do the things we do. I had a friend in hospital who was having an operation, and the anaesthetist was doing the pre-check, and he asked, did she know why she was here today? And this is what she did. She sat there in silence like, yeah, I know why I'm here today. And what operation are you having today? And again, the silence. And of course, both sides were completely misreading each other. She thought he was pretty poor at his job. He obviously didn't know what he was about to do. And he thought that she had no idea. So what was after an agonised, you know, by law, ask you to operation, he wants to see if it's a down. Again, putting this on the practitioner, and she after right leg. Okay, so those bits of information at the beginning, at the end, they could have sat each other all afternoon, you know. But an explanation, what's so natural in that environment is not obvious to the person who's come into it. And I think there's small things that can enhance health literacy. And these are just resources. Look, there's a lot from within Australia as well, but these are just things, small things like in the States, they do legislate for health literacy, it's for organisations to be health literate. So that's a huge commitment by the federal government in the United States. And that would bring about change. That certainly brings about change in practice once it's legislated for. But Helen Osborne Health Literacy newsletters, they're just a monthly little newsletter, but they have podcasts and little tips and things, and they're free. The one that is the PRISM Toolkit is for research to get good consent and in English, because it's not so plain and so there's little mini tutorials on that site that help people to really workshop their plain. And the last one, that's the last one's plain English as well, sort of thing. So they're just a couple of resources that I thought we could. Yeah. Cheers. Thanks.
Well, thank you, Kerry. And it's always good. I remember, you know, the analogy with the cup versus the. You know, my grandmother used to say, well, you know, you've got to cut down on on your sugar, how many sugars you should only have 3 spoons, but she's talking dessert spoons and we're talking teaspoons, you know, yeah, it doesn't help. You've got to be really careful. But I think there's a lot of lessons that we can learn on by looking at some of the ads that go out in relation to tackling Indigenous smoking and across the nation, and particularly I think we're changing the discourse at the moment, but just 5 years ago it was very much a government trying tobacco message should be directed to the whole population, Aboriginal. But I don't know if you remember those sort of ads that were out there seeing squeeze a sponge with the tar coming out. You had to commute into, that's your lung full of tar, or you know, and squeezing it and getting a whole lot of junk out the end of it, and that's, you know, the cholesterol in your veins. Now that might work for some, but doesn't work for everybody. So, you know, we've got to get away from the one size fits all. And that's the other level of advocacy that we need to convince some bureaucrats that you can't always one size fits all. That once we look around, the second big one is that Indigenous, you know, culture, language. There's a whole lot of groups around. We've got to work with all of them for nation. Now,
really good. I just have a question. Research came out through many. That Aboriginal people on the lowest form surgery on, I think it was kids. Yes, they just, yeah. Yeah, just listening to you talk about health literacy and just the simple by doctors, does that mean that the onus is it racism, or is it benign racism and lack of awareness?
I think you could say it could be all of them in some way. I couldn't presume to know was there an overtly racist decision where someone goes, or is there all of the stuff you said about assumptions that are made. I know, you know, peritoneal dialysis often wasn't even considered an option because of the assumptions made around Aboriginal people going to communities and yet I've successfully unpacking those assumptions behind your decision making. I've also seen research. I had an honours student, who did some research about she saw in the hospital that she assumed was autism, and when she did do the work, she found elements do I bring? And I actually would love to see something that brings health literacy and cultural safety together. But I think that's too early. Like really, we're just now having this conversation around health literacy. We've done all that work, but it's still relatively new in Australia to even be talking about health literacy. Relatively.
I think it's absolutely part of the frame of this. But I think that it comes back to what I was saying before about unpacking what we actually mean. I think trying to put everything into health literacy isn't useful. I think we actually have to unpack the different issues that we're dealing with and actually pull them apart and look at them and say, okay, this, because trying to mush it all together, I just think leads us into woolly thinking, and it doesn't help actually what might be some strategies in an act way. You have to really say this is the problem is that we're trying to address and work
just
out
signage for one thing that can
simple things like that.
You know, changed from that sort of thing that is directed at, you know, this is about speaking to particular groups of people entering the hospital. Well, no, let's make sure the signage is.
Yeah, but I think the issue about needing health professionals to they're also having at an individual level of I'm dealing with a person in front of me and I need to no matter who they are and no matter what their needs are. So then you can address those issues of cultural safety, because if they're to deal with an individual and understand what those individuals' needs and preferences and values are and provide care accordingly, then that's kind of the ideal that we want to work towards. It's hard to get there.
Thank you. You know, it's whether cultural safety or cultural competence or cultural awareness, I think we are seeing across a number of disciplines in the health side of it, and other disciplines, some movements. We've seen through the Lyme network, you know, compulsory units in medicine, now on Aboriginal health. I mentioned earlier that social work schools have got across the nation, and getting it right, I think, was a publication about competency within discipline. The Indigenous Psychologists Association have been working with the Australian Psychological Society's members to get them much more attuned. There's still a long way to go. University of Sydney, the National Centre for Cultural Competence is just being established. It's been going for a little bit, but their objective is to look at every program within the University of Sydney to make sure that there's elements of cultural competence in that, not only for Aboriginal and Torres Strait Islander people, but for working with any group of person who where English is not their dominant language and or experience. That the National Centre for Cultural Competence will then in the future start to roll out some of their learning. So we are going part of the way. I think what Nicola mentioned first up is really another great start where we've seen health ministers at least sign up, and the next is implementation and monitoring. So in progress, continually monitor along. A few people have had to go, including those online. One of the feedbacks was that found it very informative, loved the presentations, expert presentations, brilliant presentations, in fact, and discussions. So that was one. So look, so I see nobody else is jumping to their feet other than to leave, but to ask questions, is to ask Kerry to come up and give a bit of an overview about what she's got out of today's session. and all the presentations. Kerry.
Thanks. Turn it back on. Thanks. Look, I'm so glad that we were able to have this happen today, because it has been a passion of mine for so long, and to be sitting in a room of really like-minded people is just so so enjoyable on a personal level as well. Nicola, thank you for providing the broad policy framework perspective. I think the thing that Nicola mentioned is that, you know, there is a shift from the focus on the individual to the obligation on the systems. That for sustainable improvement, that it needs to be embedded into systems. That is a responsibility. And someone mentioned human rights before, and I think it is a human right to be able to receive healthcare in a safe way. Some countries even have language choice as a right in their health service delivery, and that'd be something if we had such a thing here, to embed it in the systems, to be able to communicate effectively, and to integrate into the education. I remember from my own training, I think a very small amount on communication, and it was usually you did reflect your very American style of actually didn't where I was. So I think if training at undergrad level right through and on skills, that's making a difference. I think that the project that and Angela presented just showed that it bring the weather in a way that is holistic people care outcomes, because it's not a matter of privileging one over another. If you do it in a way that is by the NPY project, then it is possible. There are others. A colleague of mine, Springs, who I don't look the same sort of thing in communities before she tries to consent. They workshop all of those terms, like what is consent, observation, collection. They find ways for people to get meaningful around that. So an excellent model. It's great that you've won awards. I think awards with this work as well. And Dawn's sense that, you know, we to look at the language we use, have a look at the systemic and the cultural around health literacy, try and get rid of dinosaur pockets, would be nice. That English locks people into certain ways of doing, thinking and being. I think that's a really powerful statement. It does. English locks people into certain ways of thinking. All language has an element of shaping people's thinking and ways of being. And so we need to recognise its value and its importance in the healthcare. You know, racism, is it overt, is it covert? Often the covert's harder to see, so we need to really unpack all of those things. I think, look, just to finish off, I think from the policy to the practice level, I hope people have found some value out of what we've shared today. I think there are things you can do as individuals that will make a difference, but one is to keep putting pressure and keep raising the issue and raising what you will actually gain by getting this right. The health service will save money, the people will have better outcomes. You know, work will be better for practitioners. There are so many benefits that we haven't even discussed yet, but there are upsides to doing this that everyone should be embracing. So I hope that people take it from here and become champions of health literacy. These ones? Yeah, I can do that. Oh, you've got them there. You want to do them, Carl? Okay, and we've brought, just for the speakers, I have no idea what's in here. It was a little gift that has come from one of the Poche NT colleagues designed this little gift, so I hope you enjoy it. And Colleen actually comes from one of Colleen's paintings. So thank you very much for making the effort to come along today. And thank you all for coming along and sitting through it. And Tom, thanks Tom.
Oh,
Yeah.
thank you, Kerry.
Yeah, we've got one for you.
Oh, for me, that's you, isn't it?
It's to you.
Oh,
I know
I'll
what's
give
in
you
that
one.
one. Thank you very much for sharing again.
Oh, thanks, then.
You always do a fabulous job, Tom. Thank you.
Yeah. Now, look, let me reciprocate by offering Kerry, our co-host, a gift from us.
You didn't get away.
She brought it down. Well, look, it leaves me just to wind up. I think I know what Kerry has just said is really a great synopsis of what we've done. I think it's really incumbent on all of us to try and take away from what we heard today and see how we might be able to, in our own workplaces, in the way that we relate to people, see what learnings we've got today that we can share and practice. Can I thank Kylie and her team at Poche Sydney for all the administration in pulling this together in partnership with Poche Flinders NT and Poche Uni WA. Thank you, Dawn. You can pass that back to Jill.
I will.
And Kerry's here. Can I also specifically thank our presenters, who we know we got a lot out of, Nicola, Nyunmiti, Angela, Dawn and Kerry. Again, thank you. Where would we be without our participants? Not only, not you guys, but all those who are online, who were online, 6 centres across the nation, and that's growing each time. We've had some very interesting comments. We didn't read them all out, but there were a few there that came in. Most of them were directed at Kerry, her staff. So we want to thank John Reid and the gang up there in Central Australia, but also yourselves, for devoting the time to come along to be able to share your views, your questions is always so critically important. And take every opportunity you can when you meet up with a bureaucrat or a politician to just continually promote the whole issue around literacy and health and justice literacy and the holistic view that they need to take when working with Aboriginal and Torres Strait Islander people. That's the only way we're going to close the gap, is by closing the health communication gap. And the very, very last is to again suggest that if you want to get some enlightenment, visit the Poche Sydney Facebook, and you'll see what they do here. Congratulations again, Poche Sydney, for your award earlier this week in recognition of the Tooth program.
Community engagement award from financial.
And of course, Bo, who's been with us since the very beginning, and in fact, he's been one of the key drivers from the New South Wales government side. And get ready to receive your Poche opinion on health literacy, closing the communication gap, which should be out in the next couple of days. Nah, not really. You put pressure on that. It'll be out in the fullness of time, as they say. But yeah. But again, thank you. I think there's still a bit of coffee outside, tea or juice if you want to. And thanks again for all your participation.
Thanks.
Oh, we finished a bit early, did we? Did we finish a bit early? It said 2:30 on here. It's 2 o'clock.
Well, I know, but everybody was pushing.
I know, everyone was...
Everybody was too efficient.
Yeah. Well, that was great, Kerry. I really love the way that your presentation brought it down to the practical. That was great. No, well done.
Now, Kerry,
that was good.
Well, that could be, but they weren't in the original one I saw.
Oh, no.
Slide 1, 2 and 3.
Okay.
Oh, I thought I was the only one.
No, I was very nice. No, I'll Kylie will have it.
Yeah, no, I'll get them for you. Yeah. So I'd like to actually, I've got quite a number of speeches coming up for the next couple of weeks. Yes. Yeah, one of them was the PHA, and but I've got to I want to again refer to this.
But I'm also,
Put in amendment, put in amendment.
That was really good. Really good. Very good. Yeah, you did a good job. Thanks for coming. Yeah, thanks for all your questions. It was great. Yeah. No problem. Yes, you're in. I think there is very good. Yeah, measure. Another time on an all facts and all the Aboriginal. Oh, and back to you. How it's going. Well, thank you very much. Thank you very much. Well, it would be useful because we have suggested doing some stuff around this, and we know we need to be doing it. Thank you.
Yeah.